again, welcome everybody. I want to thank everybody for being here today. Today we're going to talk about testing, COVID-19 testing. And this topic has been at the forefront of our country's mind since the beginning of the pandemic. And our hope is that today you'll come away with a deeper understanding, appreciation, and practical knowledge of why testing is so important, the challenges surrounding testing, who should get tested and when, innovations that are happening and kind of the future of it, and much, much more. There will be an opportunity for Q&A. So in your Zoom meeting, there's a chat box. Feel free to type any questions at any time throughout the presentation, and we'll have those questions at the end. We'll have a chance to answer them. So don't be shy, and you know, that's why we're here. So, you know, Capital City Nurses, just a quick intro, is Capital City Nurses recognize the importance of testing pretty early on with the coronavirus pandemic. And, you know, we recognize that, you know, CNAs and our nurses are the frontline first responders. They truly are the real heroes that put themselves out there every day for their families, for their own families, and for our clients. And so providing a protocol to give them peace of mind, a way to ensure their safety and the safety of their families, was very important to us. We're doing testing now weekly for our caregivers. We're in our 7th week of providing a drive-through testing for them, and the response from our caregivers has been overwhelmingly positive. So the idea for this presentation came from organic conversations that occurred as we began our testing program. It was new to us, as it is to everybody, and questions and conversations were happening, and we figured that many of our colleagues in the industry probably had many of the same questions. So we partnered with Dr. Ernest Brown, founder of Doctors to You. His practice is a concierge practice that provides premium urgent care and concierge medicine services in the Washington, D.C. metropolitan area, D.C., Maryland, and Virginia. Dr. Brown is a very authentic caregiver. He stays connected to the community through home visits. He does home visits with his clients and his patients, and he's committed to providing the best care for his patients wherever they are, wherever they call home. Dr. Brown was one of the first clinicians that I was aware of that offered testing to his patients and others when testing was more scarce than it is now. And he's been on the leading edge regarding COVID-19 testing from the beginning. So I want to welcome him. We're really looking forward to this presentation, and I hope we get a lot out of it. Dr. Brown, let me turn it over to you.
That was a sound check, just in case if nobody heard me. That's the first place I've learned to start off a conversation that's done by Zoom these days, because there have been plenty of errors in the meantime. But again, I want to thank you for the opportunity to speak with colleagues, but also I trust everyone is doing as well as can be expected. Certainly, I hope everyone is practicing good self-care. These have been very troubling times, certainly with COVID-19 and with everything now that's going on in the country. So I just want to really, for people to take a pause, reevaluate, make sure that you, your family, your loved ones, those you work with are all well supported. So again, I am a family physician. I'm born and raised in the Washington, D.C. area. I've lived here all my life, done all my training. I am a family physician, which means I treat all ages from sunrise to sunset. And I only do house calls. The reason for that is as a family physician, I feel that getting out into the community is where my greatest value is to my patients, their families, and the community itself. So certainly that would be true for what's been going on ever since COVID-19 first started getting discussed, and then when it came here. To give you some perspective, my background is in the sciences. I'm studied virology and immunology, and actually my old boss was part of the task force for the White House, and seeing him on the screen brought back some memories. In particular, it was with regards to what do we do? What's the planning now? And this was back really in January. And just having this gut-wrenching feeling that we were not going to be prepared for this, certainly on the testing end. And so I identified pretty early on that what was being offered testing, which were the providing of the kits for the nasal swabs, were going to be a problem, but also identifying that the laboratories that were being listed, it was going to be problematic to get results back in a timely fashion. And so when early on, when I was trying to work with LabCorp and Quest, unfortunately, I was doing the sampling myself. And so I made sure from the moment I sampled to dropping off the laboratory that there was no change of hands, but then the results would take up to 10 days to return. And you can imagine the agony of waiting for results. So I quickly went back to my research background and dug around and did Discover Laboratory, and I've been working with them ever since. I have personally now tested more than 700 individuals. These include patients themselves, but also those groups who are looking at screening their workforce to determine what kind of, what kind of prevalence there may be and risks associated with it. So in that time, I'm able to do the testing in the morning and get the results by 6 p.m. at night, and that has made all the difference in the world. And seeing the evolution of the testing, there's been certainly a large concern about, well, when do we test? Who gets tested? Who doesn't get tested? And seeing all of this propagate itself over time, we are still very much learning about this virus. We still have a lot more to learn. And look, where we are right now and where we will be in the fall and the winter, I'm hoping is vastly different, not only in terms of testing protocols, but also in terms of potential treatments that are effective. So the testing that we've conducted, again, it is a PCR test. So it is checking for very small amounts of an antigen or the virus itself. And when we test, we're looking at where the virus is most likely to be. But the issue is when someone acquires the virus, you don't test positive immediately. You may acquire the virus by touching the face or droplet or doorknob, but it's after the virus is in and replicating in your body that then it wants to shed. And that's the time when testing is important. Now, when you say that, well, there are people who are asymptomatic. So what do you do about that? Well, that's where the screening part comes in. For those who are symptomatic, it's trying to walk back or trace back known exposures, essentially what could have put them at risk, what's the probability. Certainly we've been testing everyone who's had even the slightest symptoms. And that's been concerning because we obviously have other viruses in the area. In fact, we have had another coronavirus, NL63, which actually had put several of my patients in the hospital over the winter. So it was concerning to see those viruses, influenza itself, and now COVID-19. So where we are now, we are certainly continuing to test individuals who display symptoms. These are the fevers, the cough, the loss of smell, which is an important one. There may be other symptoms such as diarrhea, where COVID-19 does, for some individuals, impact or they present with GI symptoms. But then also with those who are in a workforce. So we've been testing different businesses, and those businesses, some have employees of 250. And what we've been doing is setting up screening days because businesses are trying to stagger their workforce and bring people back to work, but in a safe way. And so the idea is to actually deploy teams and swap out, at least initially, and screening along the way. Obviously, if anybody has symptoms, they're immediately pulled out and tested. And again, because we do the testing in the morning, we can get the results by 6 p.m. We know what to do almost immediately. Now, there are new developments, and I'm working with a local company where we can actually get results in 30 minutes. And so that actually allows us to test 8 patients at a time. And in 30 minutes, we can get the results. So you can see that things are evolving to the point where this is, not only testing those who are symptomatic, but moving towards a point of screening the large numbers. There's even talk of using certain techniques that you can provide a sample without having to do that really obnoxious nasal swab. That's still being evaluated, and hopefully I would think by August we would potentially have a new sampling mechanism. I would say also that it's concerning for what we've seen, the sense of false negatives. And I want to bring that forward because it is dependent upon getting a good sample. And you're only as good as the sample as you get for the testing. So when we're doing it, I myself am doing it, I'm actually sampling, and it is not a pleasant experience, but I'm actually doing both nasal passages. And there's a slight twirl, and it is deep, and people will experience a level of tears, and it will feel uncomfortable. But that is what is needed to get a good sample. If we just barely put it in and not get a good sample, then we shouldn't be testing in the first place. It does have to be done right, because then you could have somebody who's falsely negative, and yet they do have the virus and can spread. Being mindful again that it is about the timing. Somebody may be infected but not show the virus. Then the point is to follow. If, say, for instance, somebody is negative and they then develop symptoms, they need to be retested. Ones who are positive, then that sets the stage for where do you test again? How do you follow? How do you manage that patient over time? So those who test positive, who are asymptomatic, we really need to test 1 week after, and then another week after that, a 14-day, which is kind of what we've all been talking about, self-quarantining for 14 days or 2 weeks. That is currently what the practice is, to test again for what is maybe another positive until they test negative. And in some cases, some will want negative tests twice. So that does mean that those individuals who are positive are going to unfortunately have to do that again. We are looking at larger numbers. We're working with other businesses to really try to figure out how to put this as part of their human resources. We are actually developing an application which will tie in the ability to actually monitor a workforce and make decisions. It will send out communications to employees on a daily basis or otherwise, to basically ping to see how they're doing. Part of it is just some reassurance that we're out there to help each other. And the other is, if somebody does, then it links directly into our testing, so that then they can get tested immediately if they're symptomatic, and then they can be cared for. And the idea is it allows businesses to set up these teams for those employees who may be COVID positive. Obviously, they're quarantining. But for those patients who, those staff members who are negative, who may be caring for patients who are positive, it's important to kind of continue the testing to make sure that everything, the staff members are okay. Because we've certainly had, I've had a family member who passed away from COVID-19, my father-in-law, and I've certainly had several patients, but I've also had caregivers who are also very, very sick. And unfortunately, that is the nature of the work that is done. And I applaud everybody's efforts, but we do need to be vigilant. So I can continue to go on. I am known to talk at length. But I'd like to just, before going on, possibly ask if there are any questions, anything in particular somebody might have right now, so that they can interject.
Hey, Dr. Brown, I have one question for you in the chat bot, and it is, based on what you see, do you think the stay-at-home order was ready to be lifted?
I have definitely seen that the numbers, testing, not only for patients, but also for the screening that we're doing with businesses, the numbers are significantly down. I think what everybody has done has been very effective. We have some concerns, obviously, with contacts now after the protests that have been occurring, whether there might be a return or a spike. But in terms of lifting, I think we are, it really is dependent upon the departments of health and the local jurisdictions. But I think I personally feel better about it. If you were to ask me that a month ago, I would have had a totally different opinion about it.
We have some more questions that are coming through.
Great.
Ms. Hackett asked, when he inserts the swab in both nasal passages, this is the same as the swab, or is this the same swab? That's the question, sorry.
Yeah, it is the same swab. The reason for doing both nasal passages is we want to be able to get as good a sample as possible, all right? And so it is not a pleasant experience. I actually test myself every day, and I've gotten used to it, but I can't be the typhoid Mary that goes around and then infects patients. So not only is it that I have the PPE, I test myself to make sure that I am negative. And that has been persistent, that I am persistently negative. But the swab itself, it has to go deep enough. And I would state that there's a great deal of anatomy involved in this. I have certainly done sampling on patients who have a deviated septum. And that deviated septum does make it harder to try and get a sample from the other nostril. And so at least I'm getting it from both nostrils regardless. But there may be times where I am able to go deeper with another one than the other nostril.
Okay, we got some more questions. Quarantine for 14 days, but what is the start from suspected exposure?
Yeah, so this all ties into the epidemiology, but also the tracing. So if there is a confirmed positive by contact, let's say if it is a coworker, or if it is a family member, or a neighbor or a friend, if any have been tested and test positive, then you are to go into a quarantine. That is dependent, of course, on your contact. Now, I've had those who have said, well, I've had almost no contact. Sometimes we may think we don't, but again, we are trying to flatten the curve. And the more that's done to kind of support that, the better. I would certainly say the 14-day period is based on the nature of the virus itself. I wish it were a 7-day, it's certainly not, but in some cases, even after 14 days. And it starts, obviously, if you test positive, it starts then. If you test negative, but you have contact that is positive, it starts when you know that there is contact. So there may be, well, we've had situations where an employee has notified their employer that they've had a family member who tested positive. So that was good responsibility of the employee to notify the employer, because then the employer, can make the preparations to allow that employee to be self-quarantined for 14 days. And it's not putting anybody at risk, and it's with the understanding that everybody's trying to work together on this. So the quarantine period, if somebody has not had contact, has not tested positive, the self-quarantine is based on activities. A quarantine is you're in a confined space. So if you're leaving that space, what are your risks? So if you are in an environment where, let's say you're working at a grocery store where there's a lot of traffic, well, your risks are higher. There needs to be a little bit more vigilance in terms of prevention. So it is wearing the appropriate PPE, gloves, which I'd like to comment a lot about gloves, and any others. Just thinking that you're in your home and that the virus still can't come to you, I do want to throw in a little bit of caution, because we've had patients who literally confined in home for 2.5 months. And 3 weeks ago, they ended up getting COVID-19. Well, how is that even possible? Well, they were every day they were ordering food from several different restaurants, and they were not really well briefed on what to do to handle materials coming into the home. And so then they both got very, very sick. Really tried to manage them at best at home, but they were teetering the edge that they really needed to go to the hospital. So, but we worked with them, gave them treatment, and they responded well. They still have suffered. They are very deconditioned. They're certainly not getting back to the regular activities anytime soon, but at least they're safe.
Okay, we've got this is great. We got a lot of questions coming in. Thank you. A couple of people are interested about antibody tests. Is there a value to those?
Yeah, so the antibody test, let's review that. So the viral PCR testing is to look at the antigen, the virus itself, and it is dependent upon the sampling. So you don't need many copies of the virus to actually test to get a positive result. You know, if there's no virus, and you've done the technique right, then you can safely say no virus at this time. The antibody testing, and we're doing it ourselves, is looking at ideally IgG antibody. We've been looking at how the body responds to a viral infection. So if you were to look at all the vaccinations that we've developed for measles, mumps, rubella, and everything, it's really to develop the body's immune system to be aware of an infection and then basically respond to that infection with antibodies which will neutralize the infection. When we look at any new infection now for COVID-19, we're looking for the exact same thing. We're looking not only for, and this is where it comes to the vaccine development, we're looking for people who have had exposures, have had symptoms, and have progressed. Those who have progressed and recovered, we then want to determine, well, what did their immune system do? Okay, so when you have the actual infection, the virus is replicating, then it starts shedding. Your immune system is going to respond, and that's why the symptoms occur, the fever, the sore throat. So you would think, well, the body's fighting this, and it's got several different mechanisms to fight any type of viral infection. And as the body learns about this infection and starts fighting it, one complement are antibodies. And the antibodies that are produced don't just show up like magic. They, when we look at how antibodies occur during an infection, one of the earliest ones is IgM. And IgM is not a great antibody, but it's one that is the kind of like the first responder. It doesn't have all the equipment it needs, but it responds pretty fast. And so that antibody is the first one to kind of show up, and it's a weak attempt for the immune system to think, well, what do we need to do about this? And that can occur anywhere for 7 to 14 days, and then, but over time, it diminishes. And then another antibody, which is where the body really learns how to fight this, is the IgG, which comes later, we'd say 14 to 21 days, and it is more potent, but it takes time for it to get to a certain level. When you have IgG antibodies, it's essentially the same as if you're getting a vaccine. That is the sense that you have immunity. The whole premise of vaccination is to give you an introduction to hope that your immune system will recognize it, and then if it comes again, it'll attack it. If we were to look at other vaccines that would be closest to this, it would be influenza, where every year, I mean, we have certain vaccines, you take it 3 times and you're done the rest of your life. Your body's got it. Well, other viruses, other infections, it's trickier. Influenza is a good example. You get the vaccine and the virus keeps doing its thing. It keeps changing. And so every year we try to guess what's going to come and we give a vaccine for that. Well, COVID-19 is not going to have the exact same immunology as influenza, but there are certain senses of it that, you know, we want to be able to provide a vaccine that's going to have enough potency that it's going to trigger the immune system to produce those IgG antibodies. To go back to the testing, then we are looking at IgM and IgG. It's just a matter of when. If somebody is recently infected and has symptoms, it's possible you can catch IgM antibodies. I have not found a single patient with IgM antibodies by the tests that we perform. Either it's missed or it's just not enough in the system. But I have certainly tested those patients really around 3 to 4 weeks after they are testing positive for IgG, which is the better antibody, and symptomatically they are recovering. Wiped out for sure, but recovering. So I can say for those patients who are developing that antibody, because I can see it, that they should recover. They need to continue to stay well hydrated, take their vitamin C, their zinc, and everything, and do some activities to kind of regain what they've lost. So the antibody testing, I think it's very important to understand immunity, what we would say maybe even community immunity. It's just another tool. Is it perfect? No. Again, it's kind of the same thing. It's a matter of you're only as good as the sample you get. It's a small pinprick, and you get a little bit of blood, put it on a cartridge, and let it run. It takes about 15 minutes, but it's a matter of time. If it's not timed right, then the probability of getting to see what the immune system, you're not really effectively evaluating all of what the immune system's response is to this virus. I hope that helps.
Thank you. Yes, and we have a few more questions that we like to make sure you have. Everybody is very interested in your view on gloves. You did say that you had a lot to say, so they are asking.
Yes. Oh, yeah. So gloves are a wonderful new addition to our 10 digits, but we already have material on our skin, which is useful for basically, it's another line of our immune system, right? The skin is certainly, but the skin secretes oils and certain things that ward off infection. It's only when you really cut into the skin that you then can get the risk, right? So one of the issues is, we already have these lovely little mitts and they are adapted to this. When we put gloves on, we are putting on an artificial barrier. So when we put on an artificial barrier, they are new hands in a sense. But don't think that that protective oil or film that's in your hand is now on the glove. It's not, all right? If anything, that glove is a magnet for everything. So as much as people talk about hand washing, I would like to say people to talk about glove washing. Just as how you wash your hands, if you are in an area and you are touching things as we are naturally doing, if you are reaching for a doorknob, just be mindful, think about it, that what that hand or that glove has touched. So I would highly, highly, highly recommend that people wash their hands with the same 20-second rule when they have gloves on, right? Just to think that you have the glove and it's protected you, you are more likely to take it from one surface and stick it onto another. Take your glove off and then grab that same surface, and sure enough, you're going to get it. So I can't stress that enough. There are some gloves do well for washing with soap. The nitrile gloves are perfect for it, I think. I've gone through boxes of gloves, and I actually use a wipe that I kind of OCD with my gloves. Certainly when I'm out seeing a patient, but also especially during testing between samples. If we have 40 people who are getting tested and I'm doing it, then I cannot contaminate samples. So one of the things is, it's not that I just have gloves and miraculously the virus is not there. I could actually contaminate a sample just with a glove.
Okay. And as a follow-up with your hands, do you have any specific thoughts about hand sanitizer?
Well, homemade Well, I think, supplies are better now than they were. I think hand sanitizer has certain limits. I'm still an old fuddy-duddy with regards to soap and water. The thing is, if you are using hand sanitizer and then rinsing your hands, that's great. But if you're just using hand sanitizer and letting it air dry, it's just a question of how effective that hand sanitizer is. And I would be a little, it's always that 0.1%, right? That's the thing. And it's the question of, well, if you've washed a surface with soap and water, I would feel more comfortable. Not to mention the fact that hand sanitizer is an irritant. And I've had several patients who've got cracking on their fingers or hands because they're using hand sanitizer so often. I would use, if you were going to use a hand sanitizer, please also use some kind of a lotion to hydrate the skin.
Okay, this person has a question about, after getting the swab, are there chances that there could be a false negative?
Yeah. Oh, yeah. False negatives. So
percentage or how often that might happen?
Yeah. So false negatives can occur by either the sampling itself or by the testing instrument. One of the biggest concerns early on were claims by manufacturers who were producing machines that they would be able to get results back in 5 minutes. Knowing that the technique that's used to do that testing, I was like, well, wait a minute. All right, 5 minutes is great, but what, so now we find out maybe 45% false negatives, and you're like, wait, that test is useless, all right? But the other part of it is, it's not even just the device and the technique, but it is the sample. I can't stress it enough. In fact, when Como went in and actually demonstrated getting the nasal swab, I saw the technique was good, but I really wanted both nostrils. The physician who tested Como actually only did one nostril, and I was like, what if it's in the other nostril? You have to think like a virus. It's not, virus is going to go wherever it wants, and it's going to sit there. And to think that it's going to be on both nostrils, not necessarily. So just do them both. It's not a pleasant experience, but it's you want, if you're going to do the test at all, you might as well at least increase your odds of getting a good sample and therefore the test being valid.
Great. I think we'll do 2 more questions. This is a question in reference to facilities. So some facilities are asking for a negative test before accepting patients into the facility. If a patient is to be quarantined upon arrival, is the test needed? This is a really long question, sorry. If the negative test is known just before placement in facility, is quarantine needed?
So again, what factors into this? So this is let me just repeat the question in a sense. So the patient was positive, but then tested negative, right?
I think, or the facility is just asking for a negative test before they can go, for the person can go in.
Yeah. So if a negative test, let's just say it's you've got, your uncle needs to get into respite or something like that, then if there should be a negative test, but then there still does need to be a 14-day period where the patient is reduced contact, or in a sense quarantine, because we don't know. Again, it's the nature of this virus, and you could test somebody negative, and then 3 days later they come back positive, right? Because you've got that time of infection. You would hope that wouldn't happen, but under the worst case scenario, then 3 days later the virus starts getting to the point where it replicates, and then in 14 days, obviously you're monitoring for temperature and those sorts of things, but there could be virus presenting itself.
Okay, and then last question. We'll make it a 2-part question to try to cover as many people as possible. Does a person need a doctor's order for testing? And then what about vaccines?
Yeah. So my personal sense is, if a physician's going to order the testing, then it is with the understanding that that patient is also going to be cared for by that patient who's ordered that. So the reason I'm doing the testing myself is then anybody who has tested positive they're receiving my care throughout the period of time until they are better, or they're counseled. It's not just, well, here's your positive result. That is not reassuring, and I think is dispassionate. I think that if this were made available, it's a question of the industry of healthcare, if you will. And this is me kind of being the Lorax, where we start talking about the economics of healthcare in the United States. And I'm not going to go into it a lot. That's another webinar. But you know, I think if the understanding is a physician is going to care for that individual who they test, then the physician should order. But if it is just shotgun approach, you know, I think it should be readily available. Anybody who wants testing gets testing. That's my point. Without a physician order, that's my point. Because what is the purpose of testing? It's to provide reassurance. It's also to help flatten the curve, right? So are we going to achieve that? Make an antiquated process more laborious, make it difficult for people to get testing, so on and so forth. If we were to look at it for testing for HIV, it's the same thing. You have a very coordinated navigation of the moment, you know, if somebody tests positive, it's not like, well, you're positive. No, there is a system in place, and people get the appropriate counseling and everything. It's not just, you know, willy-nilly. So that's one part of that question, right?
Mm-hmm.
Now,
And
what's
do you need a test? And what about a vaccine?
Okay. So we have, my background is in virology and immunology. So I actually don't watch the news at all. So if you were to ask me anything that's current in the news about this, that, or the other, but I'm looking at the research articles. And because that's where I want to see the actual results. I want to see more of the mechanism of any vaccine that they're developing and what the potential is in terms of antibodies that are produced. And in that regard, I am seeing good progress. I would say in terms of the vaccination, again, we won't know specifically well whether this will be similar to like a flu vaccine, or you know, because there are so many different strains of coronavirus, there's probably going to have to be maybe a series. It could be protecting you from other, not just COVID-19, but remember, we had NL63 that was really hitting my patients hard. So, well, if you do a vaccine that's just for COVID-19, well, what if COVID-19's cousin comes in the next year? Are we back scratch one again? I'd be more impressed with a vaccine that could really hit hard the coronavirus species, as opposed to, because, and here again, there's the sense of, you know, the vaccines are about business sometimes. And sometimes, you know, even government agencies have difficulties with getting vaccines moved through. So I would hope, from what I've been seeing, the good progress in terms of response to some of the vaccines, I would hope that fall, winter. But I would encourage that strongly, get your flu shot. If you do not get your flu shot, really don't talk to me, because if there's ever a time to get vaccination, even if the influenza vaccine, again, it's not perfect. Even people who get the vaccine can get influenza, and that's an important point. The vaccine is not to prevent influenza. The vaccine is to teach your body to learn how to fight the virus. So that means that you are still going to get sick, but hopefully if your immune system learned enough, it would not lead to much more severe consequences. It's going to be the same thing for coronavirus. Vaccine is not going to prevent it. That means that you will have it, you can still spread it, but you will recover faster and hopefully reduce the risk of spreading if you shorten the time. So I'm not going to hold my breath, but I would hope, because of where we are right now, this fall, winter, we would have something in preparation. Then it's a matter of its distribution. Are we talking about compassionate use, that means that it goes to not everyone. It goes to those who are at highest risk. Highest risk can also, I think, should include healthcare employees because they are highest risk. But those with compromised immune systems, those who are geriatric, so on and so forth. Whether there's a strategy moving forward, we have so much more to learn about this virus and strategies. But I would just come back to, again, preventative is, I think, if we had enough in place beforehand, we wouldn't have had as dramatic an effect here in the United States. And it's a larger discussion, and there are numerous factors about it. But I think where we will look back a year from now and see, well, what did we do then? There'll be a lot of headbanging. So I'll get off my soapbox.
Before we turn it back over to Sean, there's quite a few people are asking, is there a cost for testing?
Well, there was early on talk about that. Well, they talked about the testing from CMS was that testing was going to be $56, and that very quickly being that they don't have to flip the bill for it. So I don't know what it's going to be. I don't even know economically how this is going to be done, but I can tell you right now, actively, the insurance companies are lobbying Congress that they don't have to pay a dime for COVID-19, and nobody's hearing about it. So the cost for it, I mean, there are certain laboratories that for the patient, it may be ultimately free if the government moves in that direction. But right now, I mean, I didn't know. I have no idea really from LabCorp, and I couldn't get a straight answer from them. And I quite honestly, that's because they don't know sometimes. Right, especially when it's a chaos. Certainly for the month of March and April, everybody's just trying to scramble. My interest is really just what do I need to do to serve my patients the best and get it done. Whatever it takes, just do it, because life is more important than. And I understand economics, but of these things, but sometimes other things. I've certainly seen situations where, unfortunately, the economics were placed higher than the value of life.
Thank you.
You're welcome.
Bree, is that back to me now?
It's back to you.
All right. Well, that was brilliant, Dr. Brown. I think a lot of the questions that we had were answered. One of the big takeaways for me is that we've learned a lot about this, but there's still a lot to learn. So maybe as we learn more about it and things evolve, we can reconvene and have you bring us up to date on those sorts of things. But I want to thank Dr. Brown for being here, for his time, for his expertise. I want to thank Bree Lafayette Brooks for moderating and for aggregating all of those questions and making the technology work. And I want to thank everybody who attended today. I know there's a lot of things that we all have to do each day. So hopefully you found this to be very informative. And, as Dr. Brown said when he opened his talk, I hope everybody's taking really good care of themselves and stay safe out there. So thank you so much for joining us.
Thanks, everyone.
Okay.